And these are our presenters in this session. So we have Dr. Samantha S. Punzalan from San Lazaro Hospital with her research study entitled Clinical Profile of Severe to Critical COVID-19 Adult Mortalities Admitted in a National Tertiary Infectious Disease Hospital, a retrospective observational study. So good afternoon and welcome, Dr. Punzalan. And the next study is COVID-19 Antibody Rapid Testing Kit, an assessment of its specificity, sensitivity, precision, and accuracy, and diagnostic correlation to the radiologic test results by Dr. Gerardo Carmelo B. Salazar from Lucena United Doctors Hospital and Medical Center. So good afternoon, Dr. Salazar, and welcome to DOH.
Good afternoon po.
And our third presentation is entitled Transcranial Doppler Findings in Atrial Fibrillation by Dr. Jern Kans Niels B. Paber of Jose R. Reyes Memorial Medical Center. So good afternoon, Doc. So welcome for our session. Welcome to our session. Okay. So to our researchers, thank you all for joining this forum, and congratulations for reaching this far into this platform and initiative. Okay. So I would also like to introduce myself. I am Dr. Hyacinth Balderama from the DOH Health Facility Development Bureau. I am a medical specialist under the Health Facilities Development Bureau, also known now as the division I'm under is the Office of Health Laboratory. So I am a pathologist by profession, and I am the session chair for this first National Hospital Week Research Forum on Diagnostics. So I have with me is our session coordinator, Mr. Ramon Rafael Tonato. He is from the he's a project officer of the Health Facility Development Bureau of the Department of Health. So good afternoon also, sir. Okay. So I think we can proceed first to our first presentation. So can we proceed now to Dr. Punzalan on her research title, Clinical Profile of Severe to Critical COVID-19 Adult Mortalities Admitted in a National Tertiary Infectious Disease Hospital, a retrospective and observational study. So the floor is yours, Doctora.
So, can you see my slide?
Yes po.
Yes po, Doctora. Go ahead po.
So, good afternoon. I'm Dr. Samantha Punzalan, a medical officer from San Lazaro Hospital to present our paper, Clinical Profile of Severe to Critical COVID-19 Adult Mortalities Admitted in the National Tertiary Infectious Disease Hospital, a retrospective observational study. So to begin, this research study covers our mortalities from January to August 2020 at the beginning of the first half of COVID-19. So this study reports on the clinical profile and risk factors of mortalities of COVID-19 admitted patients in San Lazaro Hospital, which is one of the national referral infectious hospitals managing COVID-19 in the Philippines. So for the general objectives of my study is to review on the demographics, clinical characteristics, laboratory and imaging findings of confirmed COVID-19 mortality cases admitted at San Lazaro Hospital from January 2020 to August 2020. For the methodology, so after approval from the research ethics unit of our hospital, we reviewed all medical charts of all mortalities due to COVID-19 from January to June 2020 initially, including August 2020 to cover for the first half of the pandemic. All information that were encoded were included in a database and statistically analyzed. So included in the study were only COVID-19 confirmed deaths. probable deaths were not included at the study due to some diagnostic tests that were not done, so we could not completely classify these patients as confirmed. And at that time, the guidelines that were doing were just evolving. So we established only to involve confirmed COVID-19 patients through RT-PCR. So we were able to gather 60 COVID confirmed deaths positive for RT-PCR, where all laboratory and demographic data were included in the study. So in our study, we were able to gather an average of 60 we have gathered 60 patients with an average age ranging of 51 to 75 years mostly, with predominance of male admissions. Um, and the travel exposure of these patients at this time was not equally monitored due to, at this time, most of the patients were community acquired. So for the comorbidities, we have noted that most of our patients had hypertension and diabetes, and most of our patients were mostly infectious disease. Hence, the higher rates for AIDS and PTD patients were also noted at our institutions. Most manifestation of our patients included cough, fever, and dyspnea. For the laboratory findings, we were able to gather that most WBC counts were at the mean of 12.3, and with a predominance of your lymphocytes. We were also able to gather by the ROC score that most of our mortality patients presented with a high ROC score of more than 4.8, but these patients were equally divided at this time. ROC scoring was not established as a high uh, um, risk for mortality at this time. So PF ratios show that most of these patients were moderate to severe with ARF or your PF ratio of less than 200. Just X-ray results also showed bilateral peripheral infiltrates, and also on CT scan, predominantly patients presented with ground glass opacities. And also at this time, the medications that were advised were also included the use of your hydroxychloroquine, your antivirals, and your antiretrovirals such as your lopinavir and ritonavir. However, during this pandemic, these medications were discontinued. The use of your remdesivir or your antivirals such as your remdesivir and favipiravir continued, and also for the use of steroids that were backed up by studies were also included. So at the beginning of this pandemic, we also initiated the use of antibiotics due to the high incidence of on top of bacterial pneumonia. Hence, we had listed the antibiotics that were used. Uh, the patients were classified at this time with the basis of the community acquired pneumonia guidelines of the Philippines. So for our study, we had noted the predominance of mortality rates of males at 78.3% with ages 50 years and above, with comorbidities of hypertension, diabetes, and pulmonary tuberculosis, with the following common manifestations of cough, dyspnea, and fever. USOPA score noted also with our patients were equal to 1. 50% of the ROC score were more than 4.8. 70% of our patients showed as moderate to severe acute respiratory distress syndrome. 87% of our patients had bilateral pneumonic infiltrates, and 30% of our patients had bilateral granulous opacities on CT scan. So because of our paper, we were able to recommend at this time that since COVID-19 was still an evolving, and a lot of knowledge was still acquired at this time, we advise to increase the further profiling of our patients to improve and assist in assessment of the severity of our patients, which will lead to mortality and morbidity. And also the allocation of resources to prioritize for patients at a higher risk for mortality and morbidity of COVID-19 patients due to the following risk factors that were stated. So these are our references. Thank you.
Okay, thank you, Doctora, for the brief and precise presentation po. Okay. So if you have questions, you can key in the chat box and we will discuss it later. So now we can move forward to our next presentation. Okay. So our next presenter is Dr. Gerardo Carmelo V. Salazar. Can you share the slides? On his study entitled COVID-19 Antibody Rapid Testing Kit, an assessment of its specificity, sensitivity, precision, and accuracy and diagnostic correlation to radiologic test results. So Dr. Salazar, the floor is yours.
Good afternoon. Good afternoon to everyone. First of all, thank you for having us participate in the first National Hospital week presentation of researchers. In behalf of Lucena United Doctors Hospital, I'm presenting the COVID-19 Antibody Rapid Testing Kit, an assessment of its specificity, sensitivity, precision, accuracy, and diagnostic correlation with the radiologic test results. The novel SARS-CoV-2, which caused the COVID-19 global pandemic, reached our shores in just 3 months from its initial detection in Wuhan, China. The virus has been found in both symptomatic and asymptomatic individuals. The flu-like symptoms and variability in manifestations make clinical diagnosis uncertain. At the onset of the pandemic, the country has limited number of RT-PCR testing facilities. Turnaround time of results coming from RITM averages 5 to 10 days. There was a need in Quezon Province for a much quicker test to help clinicians segregate and classify patients while waiting for their RT-PCR results. These are the objectives of our study, mainly to validate the rapid antibody testing kit of Innovita against RT-PCR results, to determine its accuracy, sensitivity, specificity, and to correlate these test results with the chest radiologic findings. And at the end, we wanted to formulate an in-house hospital protocol for COVID-19 interim diagnostic management. This is the conceptual framework of this study. And after approval from the ethics committee of the hospital and consent coming from the respondents, we were able to collect venous sample from the following: 12 patients with confirmed RT-PCR positive results, 20 with confirmed negative results, 10 patients who were non-exposed, healthy individuals, serving as negative control, and the fourth cohort of 10 individuals have non-COVID diagnosis but symptomatic, acting basically to check for cross-reactivity. We used the antibody rapid test kit of Innovita coming from Tangshan Biological Technology Company, and we followed the manufacturer's instructions in performing the rapid test. We interpreted the results, and then after which those results were collated, and then we gathered the radiologic examination results and correlated it with the results as well. Then presented these findings to our specific hospital committees and management for the formulation of hospital protocols and guidelines and see into it that it is being implemented. And therefore, after a month of implementation, it has been reevaluated and feedback on the implementation of the protocol was gathered. Table 1 shows our negative control group, showing that these are patients testing negative for both IgG and IgM in the antibody test results. Table 2 uses now the RT-PCR confirmed positive cases, totaling 12, 9 of which turned out to have IgG or IgM positivity, whereas 3 out of the 12 did not show positivity in either IgG or IgM. On the other hand, our negative cases confirmed with RT-PCR are also negative with the IgG and IgM. So as with the non-COVID cases, turned out to be negative as well. The appearance of antibodies against SARS-CoV-2 occurs between 7 and 12 days after symptom onset. We detected antibodies on day 21 after symptom onset. Only one of the 3 samples collected less than 21 days showed IgM positive result. Both IgM and IgG were detectable beyond 21 days of symptom onset. We also tested paired sera collected during the active illness and another after 14 days of isolation and negative RT-PCR testing. We were able to demonstrate persistence of the IgG, but not the IgM antibodies beyond 14 days of testing negative in RT-PCR. This may be useful in assessing fitness of post-infected individuals for plasma donation. This is our tabular representation of the specificity and sensitivity, precision and accuracy of the antibody rapid testing kit against the RT-PCR, which has served as our gold standard. Our results of sensitivity and specificity approximates the in vitro manufacturer's report of 87.3% sensitivity as against ours 75%, and 100% specificity similar to ours. The 100% specificity and negative predictive value may be a presumptive evidence of negative COVID-19 infection. The 9 patients positive in RT-PCR and rapid antibody testing positive were symptomatic and all showed significant lung changes consistent with COVID-19 in either their chest X-ray or chest CT scan. 3 cases who tested positive for RT-PCR but not in the antibody rapid testing kit were all asymptomatic, and chest radiographs were also negative. Whether these findings imply the necessity for immune reactivity as a necessary event to develop symptoms and pathological lung changes on radiograph remains to be proven. After the validation of our antibody rapid testing kit, we adopted it as a protocol and cascaded and utilized in the hospital. A survey feedback after a month of implementation showed efficient utilization and effective implementation of the protocol. In conclusion, a rapid antibody test kit by Innovita has been validated against RT-PCR and has shown comparable results to the manufacturer's report. Rapid antibody test Innovita has 100% specificity, 75% sensitivity, 100% positive and negative predictive values, and a 91% accuracy. Likewise, positivity for IgM and IgG antibodies in this test kit correlate with significant COVID-19 chest radiologic findings. The rapid antibody testing has been used by the hospital as an adjunct protocol for interim COVID-19 diagnostic management. Its policy implications: antibody RTK positive patients can actually be labeled as high probable COVID-19 patients while waiting for their RT-PCR results. The antibody RTK negative result, on the other hand, provided a layer of confidence for negativity in suspected COVID-19 individuals while waiting for their definitive RT-PCR results. If antibody RTK is positive and these patients are symptomatic, patients would likely show significant chest radiologic findings as well. The antibody rapid testing kit, however, is not to be used as a standalone diagnostic test for COVID-19 at this point. For a period of time, it has been useful to us as an interim diagnostic management tool until we were able to set up our own molecular diagnostic laboratory for RT-PCR. I'd like to thank the following for all their help. And again, good afternoon to everyone.
Thank you for that presentation po, Dr. Salazar. Okay, so if you have questions, you can key in your questions at the chat box and we will discuss them each one later. And then we can proceed to our next presenter from Jose R. Reyes Memorial Medical Center with his study entitled Transcranial Doppler Findings in Atrial Fibrillation. So we will be giving the floor to Dr. Jern-Kans Niels B. Paber. Good afternoon, Doc. The floor is yours po.
So I'm Dr. Jern-Kans Niels B. Paber from Jose R. Reyes Memorial Medical Center, and my co-author for this paper is Dr. Jose C. Navarro. So the background of the study that presently there's only a few number of cases that we detect in cases of atrial fibrillation. So a study by Reyes, only 20 to 25% of patients are able to be are detected for atrial fibrillation. And even after performing all the ancillaries that is present at this time, all of about 70% still remain undetected for patients with cardioembolic stroke. So transcranial Doppler, which is an inexpensive and non-invasive diagnostic test for neurovascular disorders, can be used to determine the vascular status of the patients by using waveforms. So it has been observed that cardiac arrhythmias can be detected while performing a transcranial Doppler among these patients whose EKG and Holter monitoring did not show AF during diagnostic workup. So this observation led to the correlation that these abnormal TCD findings with standard EKG can show atrial fibrillation. So for this, we have patients who undergo transcranial Doppler who are patients with moderate to severe ischemic stroke with atrial fibrillation and the neuroimaging findings of ischemic stroke. An ECG, atrial fibrillation, and other arrhythmias can be seen on ECG and they correlate it with the findings in transcranial Doppler. So findings on transcranial Doppler would include flow velocity variability, spectral bandwidth, variability occurrence, and a minimal end diastolic volume changes on variability. So the objectives and the statement of the problem would involve to determine the transcranial Doppler findings that would correlate with the presence of atrial fibrillation. This in the methods, there is a cross-sectional study among ischemic patients admitted with an initial ECG tracing of atrial fibrillation, then compare it with transcranial Doppler findings and establish if there is an irregularity in the presence of TCD to abnormal Doppler spectrum. So the TCD uses a 2 millimeter hertz ultrasound probe that delivers a pulse wave echo and an 8-second continuous recording consisting of about 10 Doppler spectra that was used in the analysis of the Doppler spectrum. So we measured peak flow velocity, the variability occurrence, the spectral bandwidth, and the variability of the end diastolic velocity. Again, this is an 8-second run of your transcranial Doppler with different peaks in velocity and spectral bandwidth, as well as the percentage of variability that is seen by calculation of percentage and variance. So they will also undergo a 12-lead electrocardiogram and also underwent at the same time transcranial Doppler monitoring and then assess if there is bit-to-bit variability and variability in velocity index assessed in numerical value and assessed in difference between these values. These are then tabulated and calculated according to the duration and voltage of your electrocardiogram. So in the results and the discussions, we have 512 who were diagnosed to have moderate and severe strokes in Jose Reyes Memorial Medical Center from January 1 to 2019 of June 30, 2020, among which 94 patients presented with arrhythmias on 12-lead echocardiogram, which represents about 24% of all patients with moderate to severe stroke who present with cardiac arrhythmias. So this is a representation of a normal sinus rhythm in a patient with an NSR on EKG. So you have no presence of low velocity on variability. The spectral bandwidth is uniform in appearance, no variability occurrences between peak flow velocities, as well as there is no change in diastolic volume among waveforms. As you can also see, the beat rate variability in terms of minute meter second from end diastolic to end diastolic, as presented here, both in the left artery and the right artery, was absent in terms of and the regularity of intervals between waveform indicates that the rhythm is also regular and is also evident in your electrocardiogram. So when you compare it in the results in numerical value, the difference between variance from the mean is very negligible of less than about 1% in terms of bit-to-bit variability. When you compare it to a patient with atrial fibrillation, the peak flow can show variable peaks in transcranial Doppler sonography with a 25 cm difference seen on the right MCA territory and about 16 cm on the left middle cerebral artery territory. You can also see that there is variable occurrences on both peak flow as well as in velocity in the spectral bandwidth and a sustained variability occurrence in the minimal and diastolic volume of your patients. So this means that the variance from the mean during this time is very variable from less than 0.1% to about 50% or 49%. There was also variability in contiguous lead measurements of flow velocity in all peak flow velocities, and it is present in at least 3 contiguous variability in peak flow velocity. So in conclusion, you can say that in terms of flow velocity variability, spectral bandwidth, variability occurrence, and minimal end diastolic volume changes, atrial fibrillation presents a more than 5% in more than 2 contiguous leads, more than 5% in contiguous leads in terms of spectral bandwidth, more than 2 contiguous leads in variability occurrence, and the presence of end diastolic volume changes in more than 2 contiguous leads. The recommendation for this study is that transcranial Doppler can detect paroxysmal episodes of atrial fibrillation amongst ischemic stroke patients when you compare it with patients who have atrial fibrillation, because atrial fibrillation is in the detection is important in the secondary prevention of stroke, because it's the one that determines what kind of medications that we are going to use for our patients. Although it is difficult to capture because you can only capture about 20% of atrial fibrillation amongst these patients, transcranial Doppler can also be a way and serves as a non-invasive method for detecting atrial fibrillation, especially for patients who have moderate to severe strokes. Thank you very much.
Thank you, Dr. Paber, for that presentation po. So now we can proceed with the question and answer portion po. Are there any questions po from the chat box on our research presenters? Okay. Okay, I think there are no questions posted. Sige. So if there are none, sige, I will just ask na lang our presenters. So first question to Dr. Puntalan on her research study. Doctora, I would like to ask po, how did you stratify the laboratory data of our patients? Was it also included po in the conclusion as well as the clinical profile po elucidated from the research study po?
Yes, we did stratify our patients based on the ongoing at that time guidelines as mild, moderate, and severe and critical patients. However, during at this time, although there were already advised recommendations for laboratory workups to be done for said categories of patients, uh, not all laboratories were available, and most of especially the CRP, interleukin 9, D dimers, LDH were mostly sent out. So um, when we tried to include them in our study, we could not find a significant correlation with our patients, since not all these patients were able to uh, have this tests done. But since with the ongoing changes and with the current living guidelines, they did recommend that these tests be done. So hence in our recommendation, if profiling will again be done, this test should have been correlated, or would have been better to be correlated with these patients.
Okay po, Doktora. Thank you. In terms of the WBC count po from these patients po, based on this study po, on average po, what is the usual range of the WBC count for severe to critical COVID-19 patients po in San Lazaro Hospital?
Well, for our patients, with our mortalities, most of them were at median of 12, which we can also attribute for bacteria, but most of them all ranged from normal from 8 to 10, but uh, as the patients progressed, this WBC was noted to be at mean 12. But yes, uh, since it is a viral disease, we had noted that initially these patients would present as normal WBC count, usually from 8 to 10. And then, um, and then so we correlated the progression of the disease. We noted that the WBC count increased with, as mentioned, 12 mean for our mortality patients.
Okay, thank you po, Doktora, for answering our queries. Okay, so next question po for Dr. Salazar. Doc, I would like to ask if this is a pioneer study, no, given that this new test kit po is being validated to perform as a diagnostic modality in your institution, no? Is this a pioneer study? And follow-up question, was this test kit also validated by our ITM prior to performing the study?
Hello?
Hello po, good afternoon,
Hello, Doctor.
Doc.
Good afternoon. I didn't get the last part, sir, ma'am.
Okay, sige. The first question po, if this is this study a pioneer study po? So, given that this new test kit is to be validated in your institution po prior to performing it as one of the diagnostic tools in diagnosing COVID-19 infection po. And the second question, since all test kits needs to be validated by our ITM, was this validated po by our ITM then? This test kit.
Yep. To answer the question, first, during the time that this study was done, it was the time when there were a number of antibody test kits that were being peddled around. And I think there are only a few FDA-approved test kits at that time. And one of this was actually Innovita. And this is the only one that we have an access with at the moment. and it was the reason why it was chosen. And at that time, we were told that there is also a parallel validation study that was being done by RITM. Unfortunately, we never had the chance to get the results of that validation because everything has been eclipsed over time. Because around May or late May, we were able to set up our own molecular diagnostic laboratory, RT-PCR, and we have been using RT-PCR as a means now for classifying our patients.
Thank you, Doc, for that, for answering our question. Okay. Is there any chance that this diagnostic kit can also be used as monitoring then for, did you have plans to use this as a qualitative modality to monitor levels of antibody for vaccination po?
For the vaccination, we are planning doing neutralizing antibody testing and not actually this type of antibody testing, which is more for diagnostics. But over time, this kit has been used by some of our clinicians to follow through patients, particularly those patients who have somehow recovered from COVID-19. Just to check of the presence of their antibodies, or in some instances, it has been used by our clinicians to inform them of discharging patients from the facility. No? In particular, if the patients has been in the prolonged stay and they have been asymptomatic already, and yet their RT-PCR testing remains to be positive.
Okay, Doc. Okay, so as I understand, no, Doc, this could also be used as a monitoring tool po, especially for post-symptomatic COVID-19 infection.
Yes.
Okay, okay. So thank you, Doc. Thank you, Doc, for answering also our questions. And then for our third presenter, to Dr. Paberno, I would also like to ask for the inclusion or exclusion criteria among your subjects po, Doc, no? And how about patients with mild or transient ischemic attacks with irregularly irregular heart rate? Did you also quantify or include them? As this could also present as a paroxysmal episodes of AF.
Hello po, ma'am. For the first question, for the inclusion criteria, since we included only adult patients in adult neurology, it's all 18 years old and above who presented with moderate to severe strokes. For patients with TIA, as well as for lacunar infarcts or mga low or mild strokes, they usually present with an etiology of a small vessel disease. So the capturing of atrial fibrillation among these individuals for lacunar infarcts is more of a vessel disease rather than the cause of atrial fibrillation po, doctor. Moreover, the use of your transcranial Doppler is for large vessels, your PCA, MCA, your ophthalmic arteries, and it cannot really capture your small vessels, which are the causes for your small vessel diseases, which are your lenticulostriate arteries and your, especially in your transient ischemic attacks and your patients with mild strokes po.
Okay, so that answers the question why it's excluded po from the criterion, Doc.
Yes, pa.
And also, I would also like to ask if there are journals or studies that supports the use of transcranial Doppler as one of the modalities to determine patients with AF, atrial fibrillation among ischemic stroke patients.
This
I
is the
think this is a
pioneer.
new, ano po.
Yes,
okay.
this is a pioneer study po because this is a novel study because no one uses transcranial Doppler as a means for detecting atrial fibrillation in comparison with EKG, which is at the moment type of capturing your heart rhythms. It usually takes only about less than 5 minutes to get your ECG. But in patients with transcranial Doppler, you usually do the procedure for about 30 to 45 minutes. So you have a more time to capture irregularities among these individuals who present with irregular heartbeat patterns on waveform modalities in your transcranial Doppler. So even though there is just a chance of capturing irregularities among these individuals, but the main point here is that if we can capture these irregularities, we can treat them better, because there's a difference in treatment if you have an irregular rhythm compared to a patient who had stroke with no etiology at all.
Okay, Doc. I would also like to ask, no, usually this transcranial Doppler is a color flow po.
Yes po, it's a color flow. It's more of insonation po, Doktora. Insonation of your arteries po. It's like a mini ultrasound.
Okay, thank you. I'm not really adept po with radiology, so I think this is
It's more
this is
of more of yes po of areas of neurology wherein it's more of a specialized procedure po, doctor.
a highly specialized po. Okay, thank you, Doc, for answering our questions po. Okay, so are there any questions from the audience? Okay, I think there are none. Okay, so we will just have a synthesis of all the research papers. So again, thank you all for those presentations. So this is the, after the question and answer portion, we will have the session synthesis. So from the research as collated, we have summarized the following studies from our research presenters. So from the presentation of Dr. Punzalan entitled Clinical Profile of Severe to Critical COVID-19 Adult Mortalities Admitted in a National Tertiary Infectious Disease Hospital, the findings in this study are similar to what was reported in other neighboring countries, no? So for the demographics of COVID-19 mortalities, they are usually males with ages 15 years old, hypertensive and diabetic, and presenting with cough, dyspnea, and fever, so the classic signs of pneumonia. And the most common comorbidities noted among these patients were hypertension, followed by diabetes and pulmonary tuberculosis. So concomitant bacterial co-infections are present. However, 97% of patients were started on empiric antibiotics. So majority of these patients already needed higher oxygen support at the time of admission. And in terms of chest x-rays, most of our patients, mortality patients, have bilateral pneumonic infiltrates, while the CT scan results showed 30% having bilateral ground glass opacities. And with regards to treatment information, 35% were given investigational medications as recommended by dynamic guidelines. And I think Dr. also included na to include in the next succeeding studies laboratory profile of patients that will be helpful to in this study. Okay, so for our next research entitled COVID-19 Antibody Rapid Testing Kit, an assessment of its specificity, sensitivity, precision, and accuracy, and diagnostic correlation to radiologic test results by Dr. Salazar. The summary of our research findings involves that the rapid antibody test kits has been validated, and results are comparable to the manufacturer's report. No, so what the manufacturers claim is at par with the validation studies that they have got. And then the rapid antibody test results has significant relationship to radiologic examinations, which show a positive correlation. And the protocol and guidelines are formulated based on the results of the study, which serves as guidelines in the hospital for diagnostic and treatment purposes. And the rapid antigen test results may be very helpful, especially for post-symptomatic infections. And the use of antibody rapid testing kit and its implementation of COVID-19 management protocol has a positive feedback. And they have been using this in their institution, and it's actually very comparable with a RT-PCR testing results on its onset of positivity and 14 days after a negative RT-PCR results. And then lastly, for the research by Dr. Paber entitled Transcranial Doppler Findings in Atrial Fibrillation. So this study concludes that transcranial Doppler indeed correlates with the presence of atrial fibrillation. And it is highly recommended that the transcranial Doppler may be used to detect paroxysmal episodes of atrial fibrillation among ischemic stroke patients. And this is actually being done, especially for large vessel disease. And you cannot detect this in lacunar infarcts or TIA since it has smaller vessels. Okay, so I think that concludes our first part of our diagnostic forum for our first hospital week research forum. If there are any questions from the audience, this is your time to shine. Okay. So I think there are no questions at this point. So that's all we have for the parallel session on diagnostics of clinical and public health track of the First National Hospital Week.